Good morning, everyone. Dr. Crisanto, and for the past 23 years, I've been working as a cardiologist in acute care hospitals and private practice. Today, I want to talk with you about something that keeps me up at night, something that affects millions of people in our country alone. Medications that our patients are taking every single day, medications prescribed by well-meaning physicians, medications that are meant to help them, yet are quietly damaging their hearts in ways they don't even realize. Let me paint you a picture. Last Tuesday, a 72-year-old woman came into my clinic. Her name was Margaret, and she had been complaining to her family doctor about fatigue and shortness of breath for nearly 8 months. Her family doctor had prescribed her a few medications for her arthritis, her acid reflux, and some over-the-counter painkillers she'd been taking for her lower back pain. When Margaret finally made it to my office, what I found shocked me. Her heart function had declined by almost 40%. We did an echocardiogram, ran blood tests, looked at her medications list, and there it was, plain as day. The very medications she'd been taking to help manage her other health conditions were slowly poisoning her heart. The worst part? She had no idea. Nobody had warned her. Nobody had connected the dots between the pills in her medicine cabinet and the failing organ in her chest. This is the reality we face in modern medicine. I'm not here to scare you. I'm here to educate you, because knowledge is power, and when it comes to your heart, you need all the power you can get. So let's talk about 7 medications, 7 common everyday medications that millions of older adults are taking right now, medications that can silently, insidiously damage the heart without causing obvious symptoms until it's almost too late. The first medication I want to discuss is one that almost everyone has heard of, and many of you probably have a bottle sitting in your bathroom cabinet right now. I'm talking about non-steroidal anti-inflammatory drugs, NSAIDs. Now, I know what you're thinking. NSAIDs are safe. You can buy them without a prescription. You've been taking them for years for your headaches, your muscle aches, your arthritis. Ibuprofen, naproxen, aspirin in high doses. These are the drugs people reach for when they're in pain. And here's the thing, they work. They reduce inflammation, they relieve pain, and for younger people with healthy hearts, occasional use is generally fine. But for older adults, especially those over 65, the picture is very different. What happens with NSAIDs is that while they're reducing inflammation in your joints or your muscles, they're also doing something problematic in your cardiovascular system. These drugs inhibit prostaglandins, which are hormone-like substances that help regulate blood pressure and protect the blood vessels in your heart. When you take NSAIDs regularly, and by regularly, I mean several times a week, you're essentially removing one of the protective mechanisms your heart relies on. This leads to increased blood pressure, increased strain on the heart muscle, and increased risk of heart attack and stroke. In my experience, I've seen older patients who've been taking NSAIDs daily for years develop what we call new-onset hypertension, high blood pressure that just wasn't there before. And when we get them off the NSAIDs and switch them to safer alternatives, sometimes that blood pressure comes back down to normal on its own. The cardiovascular risk is particularly high if you already have heart disease, kidney disease, or diabetes. Your heart becomes more vulnerable. The risk of heart attack increases by 30 to 40% in regular users over 65. Think about that. A medication you can buy at the grocery store without a prescription is increasing your heart attack risk by nearly half. The recommendation from the American Heart Association is clear. If you're over 65 and you're taking NSAIDs, you should do it under medical supervision, and you should use the lowest effective dose for the shortest period possible. Let me move on to the second medication, and this one affects a huge population of older Americans. I'm talking about certain antipsychotic medications. Now, antipsychotics are prescribed not just for schizophrenia. Many doctors prescribe them for behavioral issues in older patients with dementia, for anxiety, for sleep problems. Medications like risperidone, olanzapine, and haloperidol have been used in nursing homes and assisted living facilities for years. Here's the problem. These medications can cause something called QT prolongation. The QT interval is a measurement on an EKG that represents how long it takes for the electrical signal in your heart to repolarize. When this interval becomes too long, it increases the risk of a dangerous heart rhythm called torsades de pointes, which is essentially a form of sudden cardiac death. I had a patient, a 78-year-old man named Robert, who was prescribed an antipsychotic for behavioral issues related to his dementia. His family didn't know about the cardiac risks. 3 months later, he collapsed while walking to the bathroom at night. He survived because his daughter performed CPR and called 911, but he was incredibly lucky. The EKG showed exactly what I'm describing: QT prolongation and dangerous rhythm disturbances. When we discontinued the medication and switched him to a safer alternative, his cardiac rhythm normalized. He lived another 5 years, but it could have been so different. The tragedy here is that in many cases, the antipsychotic wasn't even necessary. Many of the behavioral symptoms in dementia patients can be managed with non-pharmacological approaches, with structured activity, with attention to pain and discomfort. But because these medications are so readily available, because they're inexpensive, and because they do sedate agitated patients, they're used far too often, and the cardiac risks aren't always discussed with families. Now, let's talk about the third medication on my list, and this is a tricky one because these drugs are absolutely necessary for many people, but they still carry cardiac risk in the older population. I'm talking about certain chemotherapy drugs. Specifically, I want to focus on the anthracyclines and the HER2 inhibitors used in cancer treatment. Cardiotoxicity from cancer drugs is a real problem that cardiologists are seeing more and more of because cancer survival rates are improving. People are living longer after cancer treatment, but some of them are developing heart failure years later because of the drugs that saved their lives. Doxorubicin, daunorubicin, and similar anthracycline drugs have a cumulative dose-dependent cardiotoxic effect. They damage the heart muscle cells, and the damage is permanent. There's no way to repair it. In older patients, the risk is higher because they already have less cardiac reserve. I have patients in my practice who received chemotherapy in their 50s or 60s, lived 10 or 15 more years, and then developed progressive heart failure. When we look back at their treatment records, there it is, the anthracycline dose they received 20 years ago. The key here is awareness and monitoring. If you or a loved one has received chemotherapy, you should be followed by a cardiologist periodically, especially if anthracyclines were used. We can do echocardiograms to monitor heart function. We can start protective medications like ACE inhibitors before damage occurs. But this only works if everyone knows that the risk exists. The fourth medication is one that's very commonly prescribed, and I'd estimate that at least 1 in 4 people over 75 is taking it. I'm talking about certain diabetes medications, specifically the SGLT2 inhibitors. Now, before you think I'm going to tell you these are dangerous, let me be clear. SGLT2 inhibitors are actually one of the few diabetes medications that have heart protective properties. They've been shown to reduce heart failure risk and reduce mortality in people with diabetes. But here's where it gets complicated. Some other diabetes medications are genuinely harmful to the heart. Thiazolidinediones, drugs like pioglitazone and rosiglitazone, can cause fluid retention and worsen heart failure. They increase the risk of hospitalization for heart failure by up to 70% in high-risk patients. And yet, they're still prescribed, sometimes because they effectively lower blood sugar, and that benefit is obvious and immediate, while the cardiac damage develops slowly, insidiously, over months and years. I had a patient, Margaret, different Margaret from the first one, who had been taking pioglitazone for her type 2 diabetes for 8 years. She came to me complaining of increasing shortness of breath. Her ankles were swollen. She was gaining weight despite not eating more. When we did an echocardiogram, her ejection fraction was 30%. That's severe heart failure. She had developed cardiomyopathy from the medication. We got her off the pioglitazone and switched her to safer alternatives, but the damage to her heart was permanent. She'll need heart failure medications for the rest of her life. The lesson here is that even though treating diabetes is important, and it is, the specific medication you choose matters enormously for your heart. If you have diabetes or are at risk for heart disease, you should be on a diabetes medication that's been proven to protect the heart, not damage it. The fifth medication is actually a class of medications, and it's something I see cause a lot of harm in the elderly population. I'm talking about anticholinergic medications. These include certain antidepressants, antihistamines, urinary antispasm medications, and many others. Anticholinergic drugs work by blocking acetylcholine, a neurotransmitter in your nervous system. They're used to treat everything from overactive bladder to depression to allergies. Here's the problem. Your heart relies on the parasympathetic nervous system, which uses acetylcholine to regulate heart rate and maintain healthy rhythm. When you block acetylcholine, you increase sympathetic nervous system activity, which increases heart rate, increases blood pressure, and increases the workload on your heart. In older patients, regular use of anticholinergic medications has been associated with increased risk of atrial fibrillation, a dangerous irregular heart rhythm. It's also been associated with increased risk of cognitive decline and falls, which compounds the danger. I had an 81-year-old patient, Henry, who was on 3 different anticholinergic medications. One was an antidepressant for his anxiety, one was an antihistamine for his allergies, and one was for his overactive bladder. When he developed atrial fibrillation, we weren't sure what the cause was initially. But when I went through his medication list carefully, the anticholinergic burden was obvious. We switched him to alternatives: a different antidepressant without anticholinergic properties, a different antihistamine, a different bladder medication. Within 2 months, his atrial fibrillation spontaneously resolved. He didn't need cardiac ablation or medications to control his rhythm. Just removing the anticholinergic burden fixed the problem. This is a huge issue in older adults because the cumulative anticholinergic burden is often not recognized. Patients are on multiple medications, each with some anticholinergic effect, and nobody adds them up and recognizes the total burden. But pharmacists and doctors should be doing this. When you're on multiple medications, ask your pharmacist about the total anticholinergic burden. It matters. The 6th medication I want to discuss is something that's prescribed very commonly for pain, and that's Tramadol. Tramadol is an opioid pain medication, and while opioids in general carry risks, Tramadol has a specific cardiac risk that's worth understanding. At higher doses, Tramadol can lower the seizure threshold, but more importantly for our discussion today, it can affect heart rhythm. It can cause QT prolongation, similar to what I mentioned with antipsychotics. It can also cause serotonin syndrome if it's combined with certain other medications, and serotonin syndrome can present with dangerous heart rhythm disturbances. I want to be clear about something here. I'm not anti-pain medication. Pain is real, it's significant, and it needs to be treated. But in older adults, we have safer options than opioids for most types of pain. Physical therapy, topical agents, non-opioid medications like acetaminophen at appropriate doses, nerve blocks, exercise, these should be tried first. If opioids are necessary, they should be used at the lowest effective dose for the shortest period possible under close medical supervision. Tramadol, in particular, should be avoided in older adults with any history of cardiac arrhythmias. I had a 74-year-old patient named William who was prescribed Tramadol for back pain. He was on a relatively high dose, about 400 milligrams a day. He developed palpitations and dizziness. When we got an EKG, there was significant QT prolongation. We discontinued the Tramadol, put him on a different pain management approach, and the QT interval normalized. Now, let me talk about the 7th and final medication on my list, and this is one that might surprise you because it's actually a heart medication itself. I'm talking about certain calcium channel blockers, specifically diltiazem and verapamil. Now, these are excellent medications for controlling blood pressure and heart rate, and in younger patients with normal heart function, they're safe and effective. But in older patients, especially those with certain types of heart disease, they can be problematic. These medications slow the heart rate and slow conduction through the AV node, which is the electrical pathway in your heart. In someone with normal cardiac conduction, This is fine. But in someone with pre-existing conduction disease, and this is very common in older adults, these medications can cause complete heart block. I've seen patients who develop symptoms of syncope, fainting, dizziness, fatigue, and when we checked their EKG, they had advanced AV block caused by calcium channel blockers. We had to remove them and switch to different medications. The other concern with these medications in older patients is that they can be negatively inotropic, meaning they can reduce the force of the heart's contraction. In someone with pre-existing heart failure or reduced ejection fraction, this can be dangerous. They can cause worsening heart failure, fluid retention, and decompensation. I had a patient, 82-year-old Patricia, who was on diltiazem for blood pressure control. Over several months, she developed progressive fatigue and shortness of breath. She had an ejection fraction of 45%. We switched her from diltiazem to a beta blocker and an ACE inhibitor, and her symptoms improved dramatically. Her ejection fraction actually improved to 55%. The diltiazem had been making her heart failure worse without anyone realizing it. So here we are, 7 medications, 7 common everyday medications that millions of older adults are taking right now. And I want to be absolutely clear about something. I'm not telling you to stop taking your medications. That would be dangerous and irresponsible. What I am telling you is that you need to be aware of these risks. You need to have conversations with your doctors about whether the medications you're on are the best choice for you as an individual. You need to understand that just because a medication is available, just because a doctor prescribed it, doesn't mean it's the safest option for your heart. Here's what I want you to do. First, if you're over 65, if you have any history of heart disease or high blood pressure or diabetes, you should have a comprehensive medication review with your doctor. Bring all of your medications with you. Not just prescription medications, but over-the-counter medications, supplements, everything. Let your doctor look at the total picture. Ask specifically, are any of my medications putting my heart at risk? Are there safer alternatives? What's the lowest effective dose I could be taking? Second, if you're taking NSAIDs regularly, talk to your doctor about alternatives. There are other ways to manage pain and inflammation that don't carry the same cardiac risk. If you're taking an antipsychotic for behavioral issues, ask about non-pharmacological approaches. If you're on a diabetes medication that you know has cardiac risks, ask about switching to something heart protective. If you're on anticholinergic medications, talk to your doctor about reducing the total anticholinergic burden. Third, educate yourself. Read about the medications you're taking. Look up the side effects and risks. Check your blood pressure at home regularly. Watch for symptoms like new shortness of breath, chest discomfort, palpitations, swelling in your legs and ankles, unusual fatigue. These can be signs that a medication is causing cardiac damage. Don't ignore them. Report them to your doctor immediately. Fourth, and this is crucial, work with your healthcare team. If you have heart disease or risk factors for heart disease, you should ideally have a cardiologist involved in your care. Someone who can review all of your medications from the perspective of cardiac risk. Many primary care doctors are doing a fantastic job, but they're also overwhelmed with patients, and sometimes a cardiac specialist brings a different lens to the medication question. Fifth, be an advocate for yourself. If a doctor prescribes you a medication and you're concerned about the cardiac risks, ask about it, ask for alternatives. You have the right to refuse medications if you understand the risks and benefits and make an informed choice. You also have the right to seek a second opinion if you're not comfortable with the medication recommendations you're getting. And finally, I want to emphasize something that I think is really important. Aging is not a disease. Getting older, your heart changes, it becomes less able to tolerate certain medications, less able to handle stress on the cardiovascular system. This is normal physiology. We need to respect this reality and choose medications that are appropriate for an aging heart, not medications that work great in younger patients but are harmful in older ones. I'm thinking right now about all the people out there who are taking these medications without knowing the risks. People like Margaret with her arthritis pain medication damaging her heart, like Robert with his antipsychotic causing rhythm disturbances, like Henry with his anticholinergic medications triggering atrial fibrillation. These aren't rare cases. These are real people with real heart damage caused by medications they thought were helping them, and many of them could have been prevented with better awareness, better communication, better medication choices. Your heart is the most important organ in your body. It's been beating faithfully for your entire life, and it deserves protection. It deserves medications that help it, not harm it. It deserves doctors who understand not just the disease they're treating, but the complete picture of your health, including your cardiac risks. I want to thank you for taking the time to watch this, for listening to this information, for caring enough about your health to educate yourself. If this message resonates with you, if you know someone who should hear this information, please, I'm asking you now, subscribe to our channel. We talk about cardiovascular health, about medications, about how to take care of your heart. We publish new videos every week. By subscribing, you make sure you get these videos in your feed. You won't miss important information about your heart health. And please, leave a comment. Tell me your experiences. Have you been on any of these medications? Have you noticed side effects? Do you have questions about your medications? I read the comments, and many of them actually help me understand what's important to my viewers, what questions I should address in future videos. Your comments help me create better content. They also help other people in the community who read them and learn from your experiences and your questions. If you have a specific medical concern, please talk to your doctor. What I'm sharing here is general educational information, not medical advice specific to your situation. Every person is unique, and every medication decision needs to be made in the context of that individual's health status, their other conditions, their values, and preferences. So, subscribe, comment, share this with people you care about, and most importantly, take care of your heart. Make sure the medications you're taking are truly helping you, not silently damaging you. Ask the hard questions. Demand better. Your heart is depending on it. Thank you.